It's all about quality of vision. And there are very few diagnostic devices amongst all these new things that are being thrown at you that actually measures quality of vision the way the iTrace does. It's unique in that regard. And so this new talk, I think, is going to be something that you'll appreciate. Only the iTrace measures quality of vision. And so as this technology keeps evolving and changing, and there's corneal inlays, and there's new lenses, and there's accommodated lenses, and liquid-filled lenses, and ICLs of all variety, and corneal inlays being approved in the US, very few tools are going to help you as much as your iTrace. So without any further ado, my friend Paul Singh and his talk about laser floater removal.
All right, thank you. Thanks, Ray. Thank you. Well, first of all, thanks for the opportunity to be here. I'm very honored, and just want to let you know, full disclosure, I am a novice iTrace user. So you're wondering, why am I here talking to you about the iTrace? Because I've only had it since July. But I can tell you, without any hesitation, this has made a huge impact on my practice in terms of our ability to finally prove that there's some effect that we're getting with laser floater removal. Anybody here heard of or tried laser floater removal, visualizers? Is that you? Okay, a couple people have. Well, you know, it's something that's really kind of novice now, new. In terms of laser floater removal, it's not new. And I think this is, in the past, laser floater removal has been kind of perceived a little differently, maybe not as positively. And the reason that is because of the technology. The technology we used before was not optimized for this procedure. And so we embarked on this procedure known as modern laser floater removal. And one of the reasons why previous attempts did not work very well with lasers was because in most of our lasers that we use for YAG capsulotomies, we don't have the ability to visualize all the way to the retina and back. So that red reflex that we need to know and give ourselves spatial context. Where is the floater in the vitreous, and where is the retina, where is the lens? That's a key part of success, safety, identification, and efficacy. Also, previous attempts of doing vitreolysis used, unfortunately, energy settings that were a little bit lower, 2-3 millijoules, which is what we're used to for LPIs and capsulotomies. And people were afraid to use large number of shots. So that's what kept this procedure from actually either working very well or having a positive perception. And people really believe, oh my God, how can you just blast away the vitreous? Aren't you concerned about complications as well? So what has changed? What's changed a lot is technology. And we currently use the ultra-Q reflex by a company known as LX. And what makes it different is the ability now for us to have different visualization, so basically an illumination system that allows you to maximize your ability to see the floater as well as give yourself spatial context. The other difference is the power. The actual shape of the power is different, and the energy delivery is different, allowing us for more efficiency and actually safety. And we'll kind of go through that. And I'm not going to make this a laser floater talk because I want to get to the iTrace, so I'm going to fast forward. But let me explain to you a couple of different features that are really important. So I'm going to talk to you about illumination, why this machine allows us to more safely perform this procedure. Now this procedure, I'm going to talk to you about a concept known as on and off axis. When I talk about on and off axis, I'm talking about how I use the slit lamp. So when I'm on, I'm coaxial. In other words, the light source, the aiming beam, the laser are all in the same optical pathway. When I go off axis, I'm oblique. So here you go, just to show you what I mean by that. Here I'm on axis, and then when I turn, this is considered off axis. So when I use that terminology, you'll know what I'm speaking about. So when we do this procedure, what's so important is the ability to know where you are in the vitreous. Give yourself spatial context. So here is an example of a Weiss ring, where we are in the middle of the vitreous because we cannot see the retina. So if you see here, there's the floater. It's a nice Weiss ring. And we're firing, and it's a very visually rewarding procedure. We see exactly what we're doing. And the end point is very clear. It's not that you're just moving it or pushing it away. You actually see vaporization as well. And in this case, you see how the retina is not in focus. In this illumination system, we can actually see where the retina is and where the floater is in relation. So I'm going to fast forward to that to kind of show you something there. So I'll give you an example of visualization. So here's an example of there's a floater and there's a retina. So I know at all times where the retina is in relation to where the floater is. So if the floater is in focus and the retina is not in focus, I know I have enough safety distance to fire the laser. As well as for the lens, we can actually look, and I'll show you in just a second, how we can have the ability to utilize the illumination to look where the lens is and where the floater is as well. Again, your idea here is not just pushing that away, you're actually vaporizing and breaking it apart as well. So What makes this different is also the energy delivery system. The energy delivery is different because it's actually more of a narrow rise and fall. Most standard YAG lasers have a little bit wider Gaussian curve. What they did with this laser is truncated that to allow for a sharper rise and fall of the energy. And what that does is allows for more efficiency. It's a 3 nanosecond pulse, and what's important about that, there's not enough time for heat or energy to build up in the eye. And what's really important is what happens to the energy. When you fire a laser, a lot of us are not taught about how energy is delivered into the vitreous or into the eye when you fire a laser. And when you fire a laser, you're actually firing, you're actually firing it. Here you have a small acoustic wave of energy. The laser then will come back towards a source. That distance is called a convergence zone. And one key point to understand is that it's a non-linear rise. When you increase the energy on the laser, you are not increasing in a linear fashion the amount of dispersion of energy. So in other words, if I go from 1 millijoule to 5 millijoules on my laser, I'm only increasing the energy dispersion from 110 to 150 microns. If I go from 5 millijoules to, let's say, 10 millijoules, I'm only increasing it from 150 to 210. So that non-linearity is really important from a safety perspective, which is why we can go up to higher energy settings and not be as afraid to fire the laser, because we're not seeing that increase in energy dispersion as well. So we're going to fast forward. This is just a kind of a fun video. We took a B-scan ultrasound probe, held it temporally as we were firing the laser to see what was happening to the floaters and to the vitreous. You're going to see in a second here a bunch of lines. Those lines are not laser energy, that's artifact. But what I want you to focus on is how little movement is occurring behind the actual firing. So here's a floater, and right behind it, there's very little movement of vitreous. This is at 8 millijoules. So we're not causing a massive, large explosion. It's a very controlled plasma reaction. There we go. I'm just going to fast forward this as well, just for the sake of time, so I want to get to the iTrace data. But what's beautiful about this procedure is the ability to use what we call coaxial or on-axis, which gives us the ability to see the retina, as well as off-axis for those floaters that are right behind the lens. So I can see where I am right behind the posterior capsule. So here's a couple of videos that are going to show this idea of on and off axis. So here's an example of a patient who, I'm firing a laser, I'm coaxial, I have a nice red reflex, which is great when I want to see the retina. But if I have a floater right behind the lens, how do I know how far I am behind the posterior capsule? So I'm going to do it in a couple seconds and say, I don't see very well, I'm not sure, go off axis. So I go oblique, I lose that red reflex, but you see, I'm actually able to now see that the lens, where the lens is, and where the floater is. I know I have enough distance so I can safely fire, in this case, which is a phakic patient as well. So the importance of this illumination tower is to give myself spatial context of where I am at all times from the lens all the way to the retina. And again, you see, we're not just moving out of the way. There's true vaporization of these opacities. And why this is important? Because when we look at our data, and I'm just going to fast forward one more here. There you go. Here's a video again, just showing you this idea of on and off axis, and you can titrate it. You can actually give yourself partial on and partial off axis. So here's a floater where I'm kind of going partially on and partially off. But see that big mass that's there? That mass is significant enough with this patient's complaining about quality of vision. And we're going to talk about how the iTrace has allowed me to objectively show that by getting rid of these opacities in the vitreous, we are now able to see improvement in quality of vision. And I'm going to show you some data that we presented at ASCRS on subjective improvement. I'm going to show you some data using the iTrace on objective improvement as well. But as you can see, we are truly vaporizing versus just moving it away. So when we look at our data that we presented at ASCRS this past year, the bottom line is we found out of 362 patients, about a 90% success in terms of safe, positive improvement in patients' life. On average, about 9 out of 10 improvements in about 90+% of patients. So a lot of these patients are really miserable. We're making better. It works great with solitary white rings. For those patients who I just showed you with amorphous clumps, you might have to do multiple sessions, which we found. But those amorphous clumps are the patients who complain of quality of vision. Doc, when that clump is in the middle, I cannot see, I cannot read. You hear these complaints that sound like a cataract. You do this laser floater removal, and we found these patients come back saying, Doc, I can see again, I can drive again. Almost like a cataract post-op. So I saw this, and I was so excited. I said, oh my God, we are truly changing people's lives. But the feedback I got from a lot of my colleagues was, great, Paul. Awesome, I'm happy for you. But floater patients are not always that with it sometimes. I want objective data. I want to know for sure, what are you truly doing to the quality of vision? And I didn't have an answer. So then all of a sudden I'm with Howard Edwards from LX and with Ray, and we had this idea, hey, what if we use the iTrace? Would that give us the ability to objectively show the internal optics, the improvement that we're getting pre and post vitreal lysis? So that's what I'm going to show here with the iTrace. I'm just going to fast forward for the sake of time here as well. So the iTrace, as you are all very familiar, I'm not an iTrace expert, but as you all know, it does a great job of separating corneal versus internal optics. And that was what I needed. I needed to know objectively what's happening to the internal optics. So I'm going to go through a few case studies of patients who had those large amorphous clumps in the middle of the vitreous, pre and post. These are all patients where the only thing changed was the floater removal. A lot of these patients were actually 1 day post-op. So we did them on a Tuesday night. The next morning they came in pre-dilation as well. We repeated, as Ray was there, the iTrace, and we found incredible improvements in dysfunctional lens index, higher order aberrations, modular transfer function. It was incredible. So here's an example of a patient pre-op. You see the DLI is 5.14, and you see post-operatively 8.0. Now what's really nice, you look at the HOA, goes down. Let me see if I can show you here as well. This is a pre-op 6.92 DLI. And you look at the post-op here, 9.82. And these are all patients where this is just all we changed was the floater removal. They're not dry eye patients that a year later treating. These are next day post-op as well. Or always same day post-op. You can see the MTF curve, sorry. The MTF curve is pre. So you see that arrow on the top. The modular transfer function, the area under the curve, has increased significantly. So we're seeing modular transfer function, this functional index, increasing in these patients. You look at this patient, which is incredible. The pre-op DLI 3.79. This is significantly reduced in terms of internal quality. You look at the cornea looks pretty good. You go post-op, and check this out. This is ridiculous. 10 the next day. Ray, true story. So we did this on a Tuesday night. We did the tracing. I'm doing the laser on another person. Ray comes running down the hall after he did the scan for us. And he couldn't believe, he was like almost crying. He couldn't believe how much of a difference we could see. I mean, I've never seen a big man like that almost cry, but he was like, oh my God! It was great. I mean, and we were all like jumping the whole, because think about it from my perspective. For 4 years I've done this procedure, and I know it works. I know it's safe. I know people come back and are happy. And to finally say, look, here you go, guys. You want some objective data? This is what we see. And we have a library now of these patients, pre and post, showing dysfunctional index. Look at this MTF curve coming up. Look at the difference. The top is pre, the bottom is post. That's incredible increase in MTF. And this is a phakic patient the next day. And so we're seeing on a number of these patients incredible improvements in their quality. Here's again another case, DLI of 5.45. You look post-operatively, 9.21. Here's another case coming up as well. This is the MTF. Not a huge difference in this case. And that's also important to understand. You will have some improvements in one parameter, as we talked about. It may not be the other parameter because the eye is so different. You might see a DLI improve. You might see the MTF improve. Or sometimes just HOA goes down from 0.3 to 0.1, let's say. So we're seeing in every patient, some it's all parameters, in some it's one specific parameter, depending on where the floater is, the type of floater, is it a Weiss ring, is it a large amorphous clump? And that's what we're working on now, is separating the type of floater, where it's located, with the type of improvement we're seeing with the iTrace as well. So it's really exciting as a kind of a pilot study. Here's again, a pre-op case, 7.6, here's 10. And there's another case which is really impressive. This is something Ray's going to help me with to show. Let me show the case 6 here. This is a pre and post. You can see there as well. Look at this. This is a case 6. Pre-vitreal lysis on the left, MTF curve. Post-vitreal lysis. Now, Ray, what do you have to say about this?
That refraction is ridiculous.
Explain to everybody what happened in this case.
Okay, so this patient was mapped, and they had this bizarre retinal spot diagram where the lasers just went everywhere. And the refraction is, obviously it's red, they have lots of high order aberrations. Their high order aberrations, if you know the numbers, were 0.6. Anything over 0.2 is worth noting. And so this is their Snellen E before and after. And so the idea is that when you have somebody that you just can't get our laser through, then they can't see through it. And so the ability to take that refraction change and go from that MTF curve to that MTF curve means the difference between them seeing and not seeing. And this was a 67-year-old patient, I think.
Yep.
That's what we're learning tomorrow.
You showed a high degree
And
of
then we'll give me
regularity.
the point spread function out of the empty.
Which one? This,
Actually, the cornea was pretty good.
Which one?
No,
There's one, there's a keratoconic patient that we had earlier.
No, I didn't want, yeah, that's slide there. Oh, that's,
This is a different patient, case 5, where a lot of times the lens, a lot of times what we find too is that, what I love about the iTrace is that you see these changes and you look and say, well, how come the DLI might be a little better, but the overall E looks almost the same? That's because sometimes the lens might be, or the cornea looks horrible, but the E looks good. That could be because of some compensation with the lens as well, especially in a faking patient. And so it's really been fascinating. So when you look at the data and you look at all the different parameters, you look at HOA, and there's that same, this patient here, HOA of 0.4, post-op 0.2. So we're seeing, all the different parameters that we talk about with refractive surgery. We get so focused on multifocal lenses and HOA and higher order aberrations with this and that. To me, the vitreous is such a huge part of the optical system that we've ignored for all these years. And so now to have a procedure that takes 5, 10, 15 minutes in the office with relatively low risk, we have not seen a detachment tear in our study so far. We've done over 1,400 cases. There's a study down at Boston that just got released that shows also placebo-controlled trial. No safety issues at all, no adverse events, and found a difference with placebo versus the surgery itself. So we're seeing now data coming out that is safe and effective from a subjective opinion. Now this is showing us what we've seen subjectively as well. So I think what's exciting is this machine has so many potential uses, not just for refractive, but for internal quality of vision. And when I look at this data, and I look at the type of floaters, we're actually now able to look at and say, if this kind of floater, like a white string, we may see a different change in the internal optics versus someone as amorphous clump. And we're actually now tweezing out that data on the type of location. Anterior floaters, we're getting more scattered. It's really incredible what we can see with this and how it actually shows that it's really doing what it's supposed to do. And that's what's nice about it too as well. We actually have a control arm to look at patients who have not been treated to see does the iTrace data change. And in the control arm, it's consistent. So it's not there's an inconsistency with the actual scan. We're actually seeing that it's not the inconsistency, it's the actual floater removal that makes the biggest difference as well. So I think for me as a surgeon, just to see this and to now present this, and we're actually submitting for some publications as a case series, it's wonderful to finally see from the video, patient subjective improvement, and now show the objective data to support that. It really has been fascinating. So I thank Ray and Howard for the idea because it was just a fascinating journey so far.
Thank you very much. Can you put that last slide back up? I just want to make one quick point. So this patient had all these vitreous problems, and they were 67 years old, still with their crystalline lens. And I think most doctors would assume they have a cataract and would take it out. Their DLI is still just barely above a 5, which means their vision is okay but not great. And if you're a 67-year-old and you're complaining of vision and you can't really refract them, you're going to take the lens out. But because they happen to go to Dr. Singh, and he's really into this vitreolysis laser removal because he knows it works, he does that and improves their vision dramatically. So it may be that when you have internal problems, it may not all be the lens. It could be the vitreous. And so I'm excited to work with you. This is a really cool journey. And I'll say that we had a user in our ESCRS meeting in London, Andy Luff, who actually showed the same thing with vitrectomies. And he would take the vitreous out after cataract surgery, and he said, there's always froggy bits in the vitreous, and you take it out, and the patient perks right up. Their vision's just fantastically better. And he said, people think I'm crazy. And I said, well, you may be crazy, and you may be helping your patients. But he was a delightful guy, and I sent you his paper, and I just think there's a lot we don't understand about the optics of the eye. And so the quality of vision improvement, I think, is fantastic. So thank you again. Really, really glad you're here. Let's show some appreciation. Thank you.